But what we really want to do now is, it would be impossible. This presentation that Jeremy and Tricia usually do is like 5.5 hours. So to do it in 1 hour is going to leave a lot of questions, right? So we've also got an expert in our panel, Zandra. Zandra, wave. Zandra's with Access, so everybody applaud her. There you go, thank you, thank you. Very nice. So I want to make sure, I'm going to just be coming around with the mic, and I'm going to ask you to ask your questions into the mic so we can capture it, everybody can hear. But what we really want to do is just start the process of saying, I've got a question that I think. Realize this, if you've got a question, there's probably 3 other people that have that same question but are afraid to ask. So all you're doing is doing us a favor by being courageous enough to ask the question. Okay? Who's first? Okay.
Hey guys, good morning. So my question is kind of around some of the ACO data, and I guess maybe 2 parts. One, is there data that compares ACOs with hospices and without hospices and looks at that MSSP shared savings component to truly quantifiably say, right, if you have a hospice in your ACO, your MSSP plan is going to be more effective? That's kind of the first part of the question, if you know of any of that data. The second part is, in my market, we're a CON state, and I'm the primary hospice provider for the primary and secondary service territory of a tertiary care facility. So we work very closely together, but we haven't gotten over the hump of saying, what's the value proposition for both of us to get in the ACO or the MSSP? And I'm just trying to understand how I can maybe position myself to really be a value-added player for them, because imaging, all these other things are going to save a ton more money potentially than hospice. So they tend to get more of the attention in those conversations, and just maybe how that dialogue evolves over time from what you've seen.
I don't have the mic. So as far as the data that's been shown, I don't know of a study that's been done that shows that an ACO with hospice is more successful than an ACO without. The article that I would point you to is one of the articles that we pointed to, because all of the patients that are in an ACO are traditional Medicare patients. So if hospice is saving the healthcare system and Medicare in general money, and then it's gonna, that same effect should happen within the ACO as well. So that would be the piece. As far as your partnerships and the value add, that's an innovative conversation that you have to play through the rules a little bit, and it takes a pretty in-depth knowledge. We've played with the idea of, within medical facilities, within an ACO, can a long-term care facility and a hospice combine to start their own? We talked about starting our own medical practice specifically for facilities where it's a joint venture with a facility to provide their own medical services. We've also talked, the easiest path is to get a preferred provider limited network in return for some reporting that you're able to get. But those would be my, I know they're not great answers to, but they are the best that I have at this point, because we at least are still working through the idea of what does it look like for a hospice to own its own medical provider practice specifically for frail elders that are in ACOs. Like, that's a fairly new concept. You will see that there are ACOs that are owned by long-term care facilities, that what they do is they have a tax ID number that's associated with the facility, and when the medical provider comes in to provide the care, they don't bill under their own tax ID number. They bill under the one that the facility set up, and they're paid a contracted rate for that care. So then those patients attribute to the ACO. So those are the types of things that we're starting to see. We're starting to see those pieces. We're talking about what that looks like for our partners, especially in the long-term care space, of how can they get in as a piece of the ACO better than just a preferred provider relationship. I don't know if anybody else has anything.
The only thing I would add is, if you have a large palliative care program, in order to be in an ACO or Medicare Shared Savings Program, you have to have an MSSP, you have to have 5,000 alignable lives. And so you probably don't have those yourself, which is why you see all these practices coming together. But a lot of us who have a large palliative care program, it's based on plurality of care. So even though your primary care physicians might be seeing a patient, we just had this conversation, 1 or 2 times in a year, you as a palliative care provider might be seeing them every month, and so you have the plurality of care. So that's another piece that you're bringing to the table, that you're managing these people a lot better than maybe they are, because they're only seeing them twice a year. And so it's another great reason it highlights palliative care. So that would be another place that if you have palliative care to bring to the table, because you're bringing more patients probably to the picture than they know of.
That's exactly what I was going to say, palliative care. So, palliative care is a little bit of a lost leader right now. However, it is on the radar of CMS. There's some work going on about funding that. We know that with funding, there's going to be regulatory requirements, right? And so it's incumbent upon all of us in this room and all providers to take the lead and set the standard now. So rather than, we don't just want a seat at the table, we want to cook the dinner, right? So I think palliative care is a good way to do that. And it plays in a little bit going kind of another direction, but just for a moment, right? The hospice VBID that's in CMMI right now. So, that's another way. It's a different kind of payment model, but, there's a lot of opportunity there as well, and part of the requirement is palliative care. So, having been a nursing home administrator many years ago, I see the value in having that partnered or in-house, right, care model. So that continuity of care is going to really increase your quality scores, which is going to be more attractive to your contracted payers. Does that help?
Yes.
My question is surrounding palliative care. We're in the process of looking into starting a palliative care program. And while we currently have Part B billing capabilities, we're really sort of haven't researched enough yet. So do you have to set that up like a physician's practice in order to do a home-based palliative care program, or can you just do that off of your Part B billing capabilities under like your hospice or home health?
So we have, I'm legally, I don't know how to set it up. Maybe someone else can, but we set it up as its own. Each of our nurse practitioners have their own NPI, and so we bill individually based on that provider's NPI number. And so you can hire a nurse practitioner with an NPI and say you have palliative care. It's, does anyone have any other suggestions other than that? I mean, that's as basic, yes.
So, for our organization, it's 2 separate entities. Because in San Antonio, it's a very competitive market. We are one of the most competitive markets, I think, in the United States. There's over 200 plus agencies. And I like when I hear 30-something, I hear, I'm like, wow, must be nice. I'd love to be in that market. So what we did to set ourselves apart, because everybody in our market says, we do palliative care. And their names are, such as ABC Hospice and Palliative Care, but they're not providing true palliative care. They're providing just, our nurse is going to go check. So we are 2 separate entities, 2 different NPIs, 2 different everything, and we've just aligned ourselves together. We're sister organizations. So that's what we have done with us.
So I love that answer. So I have a friend and a colleague who needed palliative care for her father in San Antonio. Probably 2 years ago, maybe. I'm looking at Laura. I'm not sure why we're buzzing, but we are. So I could not find a palliative care organization. I was not looking for hospice. I was not looking for an independent provider. I was looking for an organization. So I really applaud what you're doing because it's so important, because consumers, you know, they're looking for palliative care. And a lot of times they're looking for palliative care, although we'd like to see those referrals made early in the disease process, right? Sometimes they're in lieu of hospice. And so when we have, you know, I hope this isn't one, my friends from San Antonio, Alamo Hospice and Palliative Care, which I feel like it might be, but I'm sorry, I just made that up. I'm from Seguin. I know, thanks, Jeff. So I'm from Seguin. Does anybody know where Seguin, Texas is?
Yeah.
So we're going to call it Pecan Palliative Care and Hospice, because Seguin is home to the world's largest pecan, if you haven't seen it. So anyways, you know, those folks that need palliative care that might have that referral, they're going to shy away, right, from that hospice. Having hospice in the title of your organization. If they wanted hospice, they would go get hospice, right? So let's provide them with what they really need, is high quality palliative care at the time that they need it the most. And if it's a, you know, if it's a link to hospice later on, that's awesome. You know, that's a nice handshake there. You can, you know, that quality of care continues, you know, as we move that patient back and forth sometimes. But yeah, I really applaud what you're doing. I think that's amazing.
Well, and the one thing I'll add is if you do decide to make it its own separate organization, for those of you that haven't started a new TIN that is a Medicare billing TIN, it is not a super fun process. So it is a time-consuming process. Creating the tax ID number, doing all that is easy, but then you've got to get it PICO certified, which because we'd been around since 1978, had never had to do, which was not very much fun. And then each provider credentialed into that piece. We did set up a separate EIN 10 for our palliative care called Midland Care Physician Services to try and differentiate that, because we're also looking at doing nursing home medical directorship. So we didn't go with palliative care. We went with something that was more general that would encompass both palliative care and just really be a physician clinic. But it's definitely possible, but it's been a learning experience for me on how to enroll a 10 in PICOS and the time that actually takes. It's not something that you turn around in a week or even in a month. It's going to take a little bit of time to get set up. So just keep that in mind if you decide to go that direction.
It's for Tricia. How'd you get so awesome? No. So you mentioned you had an 85% rate that you negotiated. Was that under the same payment structure as Medicare, where after day 61 there was a decrease, and did you have the service intensity add-on? I mean, did it mirror Medicare exactly, or was it just a rate? This is the rate, and it's for all days.
No. Great question. It mirrors the Medicare benefit. It's still the hospice benefit, but they did add 2 additional benefits for the hospice patients, and I mentioned both of them: concurrent care, so they can get ongoing treatment, knowing that it's palliative in nature, and then the other piece that they did add is that they can have 40 hours of a CNA. So we can provide that CNA and also bill for that. So we got our CNAs credentialed, if you may, underneath that agreement. So that was additional. It made up for some of the revenue that we lose fee for service. So.
What's the frequency on that 40 hours?
Oh.
The frequency on the 40 hours?
So it really just he asked what's the frequency of the 40 hours of the certified nurse's aide. It just depends on, we have to call for authorization. It doesn't have to be right in a row. It could be one day. It could be, it's the whole term of the patient that we have on. Mm-hmm.
So one of your slides mentioned, and again, I'm a CON state, so we have 19 hospices in all of West Virginia, but it's also only like 1.7 million people total population. Your slide mentioned for the VBID, South Florida and Kentucky have CON, and they're still negotiating. Would be interested to hear in kind of what you've seen there. And then I forgot my other question.
So what that slide was referencing is that they are starting to reach out to certain providers, and even though it's a CON state, there's still, there's less competition. I'm not in Florida, but I know there's more that are starting to add, but historically there's less competition in CON states, and they still are negotiating discounts. That was the purpose of it.
Yeah, okay, that's helpful. My second part was about the concurrent care. So probably one of the biggest issues I see, and I was on the acute care side for a while, is the lack of ability to do like dialysis for a patient, right? And would be interested to hear kind of if this model is helping with that, because our dialysis patients, their length of stay is like a week, and it's really sad that they have to decide between life-sustaining dialysis treatment or bereavement, anticipatory grieving, all these other services. So would be interested to hear if anybody else has figured out a solution to that, or how this is playing in some of the models you're seeing nationally.
Yeah, I'm going to go back to my United Healthcare days. They had a program called ESRD, end-stage renal disease, that they actually enrolled members into that program. So they too were not real big fans of referring to hospice earlier than later. So we ended up having the same struggle, even as we were owned by the own organization, right? And we couldn't get them to move their members into hospice. It was always last minute when they actually decided that they were going to stop dialysis. So I think you would have to just, again, be at the table and find out, are there opportunities? That's a real hard choice for people to make, but when they do make it, they do need the support. So I think it's coming to the table and saying, there's an opportunity for us to support this type of patient with this type of disease, and but that's a tough one.
Hi, my name's Lloyd Wilson from Austin, Texas. Thanks so much. I had a quick question. There's a bullet point about Prospero Health and Aspen. These are care management groups that have been bought up by the big managed care providers. Just wanted to speak to kind of how they fit into the picture and what the opportunities are with them.
Let me take this one. So Aspire and Prospero. Aspire was started up as a palliative care program, advanced care planning. They are feet on the street, and what we're learning is that it's just like all of us, they have staffing challenges. And to own the bricks and mortar in an environment where many of us have palliative care programs, we really are a great solution to some of these large players who don't want to. Prospero is part of United Health Group. They started up. They're, what I've told, and maybe somebody knows Prospero better than I, but what I've been told is that they're trying to move to the model of partnering and networking in various models, whereas Aspire was actually building bricks and mortar. And so if you have a palliative care program, you are a solution because, number one, you have the expertise in end-of-life care planning, you already have the staff, you already have the relationships and referral sources out there with the doctors, and so you can set it up much quicker than having bricks and mortar set up like Aspire would do in your market. So I think some of these big Humanas and others are starting to realize that we have the expertise in getting these people along the continuum and moving them into hospice sooner than what they were doing. They're a profit center. That's what they're doing it. We're doing it, like some of us already mentioned. We probably got into palliative care to feed our hospice, and now we're seeing that it's becoming its own entity, and you can manage these patients under palliative and then move them at the right care at the right time.
Well, I think the other thing that shows is that payers are putting an importance on end-of-life care and owning the end-of-life care and being able to own those costs. So you look at Landmark, you look at any of those. We had a conversation with some of our managed Medicaid providers about a year ago, and they historically have referred to us for palliative care and hospice, and they were talking through that now they're going to try and develop what they would call kind of a hospice light, a different way to do hospice where they're not actually going and referring to an outside provider to provide hospice care. They're using their palliative care team to provide hospice. We do something similar in PACE. They don't come off of PACE as a payer to then go receive their Medicare benefit. We keep them on PACE until death, and we use our staff, and we contract out with our hospice staff and our palliative staff to provide the end-of-life care. But you're seeing some of the larger providers that are starting to buy up some of these business units start to think of how they can do that, because you eliminate a lot of your cost when you're able to keep that in-house. So I think you're seeing a lot of those acquisitions. We've been seeing it for years in the home health and hospice space, where providers are buying up home healths and hospices, and now we're really seeing it in the palliative care space as well, where they're controlling that entire continuum. And again, when you get into VBID, obviously the people you own are probably going to be one of the people you contract with. And so those are some of the conversations we're starting to see around that.
Yeah, I just had a clarifying question for y'all. So when you're talking about your involvement in an ACO, is that as a contract vendor, or is that as an ACO owner, or do y'all participate in any of the shared savings?
So the 10 people that were on the screen actually own the ACO. So we went all the way in when we did it. We didn't just partner or contract. We started, developed, we run and manage. It's its own entity. So we went all the way. So we also are participating. So our palliative care program is in the ACO, and we also have partner doctors for us in Topeka, for them in Denver, that we have recruited into the ACO, that we're providing the palliative care interventions within the facilities for those docs to try and keep them in the facility and not going to the hospital. So it's kind of a combination of both. From the highest level, we are the owner, but we also are one of the providers that are contracted to provide the services within the ACO.
Contracted provider, which is always considered a cost, correct? Even looking at county hospital referrals, so
Correct.
If they're looking at sharing, if you're looking at cost savings, you don't want early access to hospice. You want timely access to avoid treatment and acute care facilities. So how do you see that challenge as a vendor, being able to get timely hospice referrals and not late hospice referrals as unintended consequence of crossing?
So the conversation we have all the time is we need to stop thinking of ourselves as a step down from the hospital and think of ourselves as a step up from home without care, and start to sell ourselves as not the thing that's a level below the hospital, but we're a level up. We're the bridge in between. Even for those of you that might have a hospice house and inpatient facility, instead of saying, this is for people after a hospital admission that, we free up a hospital bed, we give them end-of-life care, and they're done. Well, this is also for a patient at home that we're referring directly into the hospice house. And instead of that ACO paying for a hospital stay, they're now paying a cheaper rate at the hospital house, and we're getting better care and better outcome in the end. So that's the messaging that we've started to give is there is a cost associated with our service, but we feel like our service is priced at a point that the alternative of an acute care hospitalization, so that's really where we center the conversation, is the prevention of acute care hospitalization. When you talk and you even extrapolate it out to PACE a little bit, we talk about hospitalizations ad nauseum. The IDT team for PACE meets daily and covers every single person in the hospital and how can we get them out. And if hospice is a way that we can keep someone from going to the hospital, or that end-of-life care is a way that we keep them from going to the hospital, we will refer to that in a second over sending to the hospital and then the other way. So I think it's a reframing of where our service line is. For any of you that go to any of the national conferences and talk or hear Bill Dombey speak, he talks about how we need to stop calling ourselves post-acute care. We're frail elder healthcare providers. We're whatever you want to say it, but we're not a just post-hospital service line. That's not our role. We can be a direct access from the facility. If you're in the ACO and they're looking at cost, and you can get a timely referral to hospice, and by doing that you can track your data and you can be able to say, hey, your hospitalization rate for your patients has decreased by 15% over the last year. Well, that's a savings to the ACO. That's way more than what they're paying. But you are right, if you don't do a timely hospitalization, a timely admission to hospice, those last few months of life become the most expensive months of their life, because you are paying for hospice every day for, let's say, 90 days instead of what was really a 45-day needed stay. So I don't know if that answers the question. That was a really long-winded way to maybe not answer your question, but hopefully that's. I really think we need to start considering ourselves as a step up from home, not a step down from the hospital, if you're going to take nothing else away from that. So.
This has been great. Question, on one of your slides you mentioned about palliative care, unless we can show you value, or we have to be able to show you value. One of the things I've had the hardest time with in palliative care is getting the data to show the decreased hospitalization rate, because I don't have payment data. I can only show you how often my program touches your patient, medication changes that we've made, but I can't compare my 70-year-olds with COPD that have my palliative program to those that do not, and how much greater our palliative care program is. How can I get that data to go to an ACO, go to a group and say, this is how awesome we are and this is why you need our program, because this is how much money we can save you?
So what we've done historically, it's not easy to get. I don't want to minimize that at all. That data does not readily exist. It's a grassroots, boots on the ground effort where you find a partner that's willing to partner with you, and whether it's a facility or a hospital system, you say, here's what I want. Here's what I want to figure out is I want to know how to bring value to you, so I would like to do a trial. Let's look at, can you get me, your last year of hospitalization data, and we're going to run out over 12 months doing advanced care planning on all new admissions and making sure they have an advanced care plan in place. And we have these 4 palliative tracks that any patient that comes in with that diagnosis, we're going to put them in, and you get an agreement from that partner that we're going to do that. And then you have, but it's a long process. It's not something you can go today and say, hey, I got that data. I admitted 5 patients last week, so now I have the data. It's a year-long process of grassroots. That's what we've had to do. We've done that with our hospital providers. We're actively doing it with our facility providers within the ACO. The advantage, if whoever you're talking to is in an ACO, they do have ready access to that data. You need to have a good enough relationship and be at the table enough for them to share, hey, you saw these 25 patients and here's their hospitalization rate compared to the average ACO. So that's another way to go about it, because we do get dumps of data on pretty regular basis that are easy to analyze. Well, not easy, but they're burdensome, but it can be done. So
there are hospices that are staying out of the ACO business altogether. At what point in the timeline, in this continuum of change, will a hospice be faced with the challenge that they don't have a choice? Is this inevitable?
Is VBID and ACO inevitable? Absolutely.
VBID is inevitable.
And
ACOs are inevitable.
we are,
Yes.
and I think I kind of said this before, the conversations in the conferences I've gone to before is, hey guys, let's start crawling so that way we can walk. So that way when we're ready, we can run. We're past the part of crawling and walking. We need to start jogging towards embracing this. And it's not just small companies that possibly have their head in the sand. In my opinion, it's some of the larger companies that think they are too big to fail with hospice. I'll give you an example. We have a competitor in an area in Kansas City that if we would come in and get the VBID contract, because Kansas City is 50% Medicare replacement, and we take approximately 50% of their Medicare, of their referrals away, they all of a sudden are probably not going to be able to sustain themselves. So it's something that everyone needs to be looking at now and needs to be figuring out, so that way they have a seat at the table.
Mm-hmm. So, I agree wholeheartedly. We all agree.
Yes.
We're going to get to that point very, very soon. And for VBID, what I would encourage you all to do is go to the VBID model page, the CMS model page. Look at the 2023 and soon to be 2024 application process for the hospice VBID model, it is going to tell you exactly what the Medicare Advantage organizations have to report, right? And so we know what they have to report. So when it comes time to get that contract done, we have that data and we're able to be competitive, right? And we're able to attract that business. So the tools are out there. It's kind of like it's a lot easier, right, than claims data to ingest, but it's certainly out there, and just with a little elbow grease and some thought, everyone should be able to be successful. It's not going to be easy.
I was just going to say that we had a conversation on the break. I doubt that there's very few physician practices that aren't getting 2 to 3 phone calls a month, about wanting to join an ACO. So even your referral partners, this is on their radar. So you need to be very familiar with what they're dealing with, because they're going to be in an ACO, which they have shared risk. And so they're looking for solutions. And so if anything, you need to be able to come to the table to say, I'm your solution and here's why. And again, I said technology, you've got to lead with data. You've got to know your scores. You need to know what your readmission rates are. That's what's going to make you and set you apart from some of your competitors.
Thank you, everyone, very much for your help on this panel. We appreciate it very much.